this exciting webinar that we have planned today. Again, first and foremost, thank you to the HPBA for helping to organize this, and also thank you to Genentech Roche for sponsoring this. And we have a very exciting speaker agenda today and some fantastic experts talking about some exciting things. I'm seeing a lot of people on the call already. Just to kind of give it a really quick update, we're going to do the 4 talks first. They're each about 12-15 minutes. We'll get through all the talks, then we've organized about 30-35 minutes at the end for an interactive discussion. This is set up that you will be able to come on camera, be able to unmute, and also be able to speak. So just raise your hands, and I'll be doing the best I can to moderate as we start getting 25, 30, 50 people on here. So with no further ado, we'll start with our first talk. Our first speaker is Dr. Daniel Borja. He's a transplant surgeon here at Northwestern, one of my partners and friends here. He is a fantastic transplant surgeon, but also one of our leaders in growing our transplant oncology program here. And his topic will be looking at optimizing patient selection for transplant for intrahepatic cholangio. So Dr. Borja, I'll turn it over to you. You're muted. Daniel, you're muted.
Can you see my slides now?
Not yet. There we go. We got it.
Perfect. Thank you for the invitation, Dr. Maitel. It's my pleasure to talk to you today about the selection for transplant for intrahepatic cholangiocarcinoma. These are my disclosures, and none of them are related to this talk. I'm going to talk first a little bit about what we're going to be talking today. Cholangiocarcinoma. One of the biggest challenges that we have for the evidence is at the beginning, there was a lot of misleading with coding and with the trials. Cholangiocarcinoma can be classified in 3 based on the site of origin. Intrahepatic cholangiocarcinoma, which arises proximal to the secondary biliary radicals, which we see here. It comprises about 5 to 10% of all the cholangiocarcinomas. Hilar cholangiocarcinoma, which in United States is the most common, 50 to 60%, which arises in the right-left hepatic duct, the confluence, and proximal to the confluence of the cystic duct. And finally, extrahepatic cholangiocarcinoma, 20 to 30%, which is distal to the cystic. I am going to be talking, my talk is going to be exclusive about intrahepatic cholangiocarcinoma. As you know, the second most common malignancy, 10 to 15% of all the neoplasms, and the problem that we face every day is that most of them are advanced, and it's not uncommon that we see very large tumors, completely asymptomatic and found to be incidental. The surgical resection is the mainstay of treatment. However, only 15% of front are candidates for surgery. There's a big percentage of recurrence the first 2 years. And it's very important to do the lymph node dissection at the time of the surgical resection. This is very important for liver transplantation before proceeding for transplant as well. As you know, very frequently the tumor presents multifocal. It's not uncommon that the FLR is very small. It's not uncommon that the patient has the compensated liver disease and we cannot do an aggressive resection. The 5-year survival for all stages, including patients that go surgery, 5 years is less than 7 to 25% of the persons. Adjuvant therapy, I'm just going to briefly mention that is based on this trial, that although it was initially for patients that had stage 4 disease, basically it set up the gemcitabine cisplatin therapy that we do nowadays for all our patients. And in this trial improved 4 months. Intrahepatic cholangiocarcinoma can be classified in mass-forming intrahepatic cholangiocarcinoma and periductal infiltrating. In the mass-forming, we're not going to see any dilation of the bile duct. We're just going to see the mass inside of the liver, as opposed to the growing inside of the duct with dilation proximal to that or growing along the bile duct. This is important because most of the trials that have focused on liver transplantation, if you read, are focused on the mass forming the peripheral subtile. They have different mutations as opposed to the perihilar. It's more common to have these 2 mutations, the isocitrate dehydrogenase 1 and 2, and the fibroblast growth factor receptor number 2, as opposed to the common mutations that we see in the perihilar, which is KRAS and TP53. This is important because the risk factors that we know, the chronic hepatocellular damage tends to predispose to this, and the chronic biliary inflammation like PSC, like choledochal cyst, tends to predispose to these ones. However, we can see all sorts of combinations, meaning patients with cirrhosis can develop this one. 50 to 60%, there's no clear risk identifiable, meaning there's not going to be cirrhosis. The tumor is going to be advanced. And in a recent publication in Annals of Surgical Oncology, we saw that these patients with this type of tumor tend to be patients that don't have R0 resection, lymphovascular invasion is more, and perineural invasion is more. The reason to bring this is because this is important when we start talking about transplant. As you can see the difference in survival, the blue line shows what's the typical survival after resection if we do the mass type versus the peripheral. Liver transplantation initially was associated with very poor outcomes. One of the reasons was that very frequently it was mixed with other type of tumors, like I mentioned before. Perhaps the most important evidence was 11 years ago by Sapisuchin. This is a retrospective study that included 16 centers in the United States. It included almost 8,000 patients in 10 years, and about 30% had suspected HCC at the time of the transplant. None of these patients were transplanted with the indication of cholangiocarcinoma, and this study, as I mentioned before, is retrospective. In the final pathology, we see that 29 patients had intrahepatic cholangiocarcinoma, and they divided in advanced, defined as more than 2 centimeters, versus early, less than 2 centimeters. And as we can see, the risk of recurrence was significantly higher in those tumors that are more than 2 centimeters as compared to less than 2 centimeters. In a different analysis that they did in the supplemental, they saw that tumors up to 3 centimeters had better survival, and that's going to be one of the main selection criteria that we're going to use nowadays. Not surprisingly, the patient survival was better in the patients that have a tumor less than 2 centimeters as opposed to the patients at 2 centimeters. The 5-year survival for these patients was close to 80% as opposed to 40%. This was validated in a very similar international study that included now 25 patients, 30% with HCC, and similar thing. At the end of the study, they showed that patients with less than 2 centimeters had a decreased risk of recurrence as opposed to patients with more than 2 centimeters. The 5-year survival in this very early, less than 2 centimeters, was about 70% as opposed to 50% in advanced group. This set up one of the early findings that patients less than 2 centimeters with cirrhosis should be transplanted. However, the limitations of these studies were that the size, how frequent we see patients with less than 2 centimeters. Most cases were limited to incidental finding after transplant, and definitely there was no role of neoadjuvant therapy. A landmark study that was published in Lancet Gastroenterology and Hepatology in 2018 evaluated for the first time what happens if we give to these advanced tumors, which they use the same definition used by Sapisuchin, more than 2 centimeters or multifocal. They evaluated the role of neoadjuvant therapy prior to transplant. All of these tumors were biopsy proven, not amenable to surgery because of the location of the FLR, and evidently no extrahepatic disease. All these patients received 6 months of therapy. The first line was based on that trial that I mentioned before, and it was most of the patients gemcitabine combined with cisplatin. For those patients that progressed or didn't tolerate, it was a second line, which in many patients was FOLFIRINOX. And they had to show for at least 6 months a stable disease. The imaging was repeated every 3 months, no extrahepatic disease. Patients were transplanted and had adjuvant therapy for 6 months after the transplant, and it was started for 6 weeks after the transplant. For The first time we were evaluating the role of neoadjuvant therapy, and something that is very important when we're trying to decide which patient benefits versus which one doesn't benefit is the disease has to be stable or regress for at least 6 months. 21 patients were included and they transplanted 6. The primary outcome of this study was overall survival. You can see that 85% of the patients were alive after 5 years, and the disease-free survival at 5 years was 5. 1 patient died of recurrent disease, and 2 more recurrences that were able to be treated with therapy. For the first time, they start mentioning the role of mutations. This study was validated by the same group 4 years later, now included 18 patients, and you can see that the median age of the patients was 49.6. This is important because what has happened in this period is that we have seen an increase in the incidence and is more prevalent now in younger population. The median size, as opposed to the previous study, was 10.4. It was not uncommon that patients had multifocal. Most of them were transplanted with deceased donor, but they have 3 living donor liver transplants. All patients were treated with a gemcitabine-based regimen, most of them with gemcitabine cisplatin. The median time to diagnose, from diagnosis to listing, is 329 days, which is very important. For the first time, we are changing the tumor size, instead of thinking about the tumor size on the novel model, to see the tumor biology. That's why it's important to watch these patients. And from the median time, from the time that they were listed to transplant, is more than 5 months. The tumor biology became more important than size. And we can see that it was not uncommon that they found mutation. It was not significantly different, but they start talking about these mutations that I was mentioning before. They found that as opposed to those patients that were not transplanted, and all of them were dead after 2 years, 57% survival after 5 years, compared to historical controls in patients unresectable, that is 16.7 months. And the recurrence-free survival for these patients that were transplanted was 52%. Future studies start including the use of other drugs. The current standard of care, as all of you know, for patients in this population before surgery, before transplant, is gemcitabine cisplatin. However, based on this clinical trial, we start using in some patients durva prior to transplant. This is a study that was published in New England Journal of Medicine a few years ago, and that basically showed that as opposed to placebo, the number of patients that, the median overall survival was increased. And in the future, we're talking about all these potential mutations in patients with intrahepatic cholangiocarcinoma. Perhaps the most promising are the mutations in the fibroblast growth factor receptor 2. There are clinical trials that are evaluating right now the role in patients with intrahepatic cholangiocarcinoma without transplant, but in the future, the role is going to be evaluated. And as I was mentioning, also this mutation, the isocitrate dehydrogenase. Surgical resection is the current standard of care. However, liver transplant should be considered in those patients with tumor less than 3 centimeters, in patients with cirrhosis. As a matter of fact, nowadays, UNOS accepts us to have exemption points in patients that meet these criteria, obviously in the absence of extrahepatic disease. Tumors need to be considered unresectable even in the absence of cirrhosis, but it's recommended that it's done in multidisciplinary teams with a lot of experience, at least 4 to 6 months, in which we prove that the disease is stable or regresses with neoadjuvant therapy. The current therapy is cisplatin gemcitabine. However, target therapies are becoming more common. Thank you.
That was fantastic, Dr. Borja, perfectly on time and just rich with so much information that will be the foundation for a great discussion in a little bit. So we'll move on now to Dr. Angie Wall, a transplant surgeon from Baylor Scott & White, who very interesting viewpoint on how can we optimize the donor pool for transplanting for cholangio, looking at machine donor, DCDs, but also touching upon the ethics of transplantation for biliary tract cancer. So Dr. Wall, all yours.
All right, great. Thank you so much, Dr. Maital, for the invitation to talk with you all today about optimizing the donor pool for intrahepatic cholangiocarcinoma. I really want to thank Dr. Borja for setting up all the data because my talk is very limited in data because I want to talk really about kind of conceptualizing the use of different types of grafts for intrahepatic cholangio. This is my one disclosure. So what we're going to talk about today are current guidelines and outcomes, just a little bit of data on outcomes for intrahepatic cholangiocarcinoma, describe some considerations for utilizing extended criteria grafts with in situ and machine perfusion for intrahepatic cholangiocarcinoma, and then a little bit about creative use of different types of extended criteria grafts. And then finally, I'm going to switch gears and talk about consideration for living donation in liver grafts for intrahepatic cholangiocarcinoma. And my hope is that through this talk, I convince you that there are actually different considerations between the deceased donor grafts and living donor grafts because they truly come down to a different ethical analysis. So let's start by talking about the baseline MELD exception for cancer. MELD is, as we all know, used for the prioritization in the allocation of liver grafts, and it reflects disease severity, which is 3-month mortality without access to liver transplantation. And so this is an urgency criteria. This criteria is the urgent need for liver transplantation, but the issue with using urgency criteria is that it's not reflected. The MELD score doesn't reflect different types of urgency. And so what we see is that MELD exceptions, we have to have MELD exceptions for some different types of disease processes because the risk of mortality or the waitlist dropout are not determined by the MELD score, but more about the complications or the progression of liver disease. And so MELD exceptions recognize the degree of disease severity in cancer patients, but they are also limited. So when we think about MELD exception for cancer, I think it's really important to note that these exceptions are limited to individuals that have acceptable survival. And the historic benchmark for acceptable survival for MELD exception in the US was based on hepatocellular carcinoma as the first test case for utilizing a standardized MELD exceptions. And the outcome for HCC in the early cohorts of HCC patients for liver transplantation was a 60% 5-year overall survival. So that's sort of the benchmark that we've set in the US. I will show you that has changed slightly, or it has changed over time. So let's start with the benchmark case of hepatocellular carcinoma. So what you can see is that the median survival for ICCA, or for intrahepatic cholangiocarcinoma, is in this one of many studies is 23 months versus 69 months for HCC, and then the 5-year overall survival is lower with cholangiocarcinoma versus HCC within Milan criteria. So when we look at cancer versus cancer, both the median survival and the 5-year overall survival outcomes are worse with transplantation in the intrahepatic cholangio group. And the reason that I bring that up is that that's what builds into the way that we have MELD exception points for intrahepatic cholangio. So instead of with HCC, you have a standard exception. So if you meet X criteria, that person gets a standard exception points, which is median MELD -3 at transplant. And so intrahepatic cholangio is not a standard exception. You have to write a narrative, and you have to show that that the patient's tumor is within all of these different criteria. And we've already talked about these criteria: presence of cirrhosis, unresectable, local, regional, or systemic therapy has been done, biopsy proven, and then 6 months from the time of diagnosis or last treatment of tumor stability. So it is not guaranteed that your patients with intrahepatic cholangiocarcinoma will get MELD exception points. And what that means is that they're kind of two pathways. So if you get MELD exception points, which is median MELD -3, it means that your patients have a good chance of being competitive for a reasonable liver graft. But you also have patients that you think will benefit from transplantation with a deceased donor graft that don't meet these criteria or that will not get MELD exception points. And so if you do not meet your acceptable survival, or if you don't have if your patient doesn't get MELD acceptance points, then we can't argue for MELD exception, right? If you don't meet acceptable survival, we're not going to give MELD exception points, but can we use deceased donor grafts? And I think that this is the question. And what it boils down to is a question of what makes a graft marginal or what makes a graft extended criteria. And there are a lot of things that make grafts extended criteria. It can be donation after circulatory death, older grafts, macrosteatosis, and long cold time. And I'm not going to go through how we treat graft or what each one of these sort of extended criteria situations are. But the reason that I have this diagram on this slide is that I think the bigger argument is to say that extended criteria grafts the risk of those grafts can be mitigated. And it can be mitigated or it can be at least decreased by utilizing machine perfusion technology. Sometimes that machine perfusion technology is NRP or normothermic regional perfusion. Sometimes that machine perfusion technology is XI2, normothermic machine perfusion. Can also be hypothermic oxygenated machine perfusion or hypothermic back to controlled rewarming. And the bottom line is that the utilization of one or multiple technologies to intervene on grafts that have one or more risk factors for being extended criteria has the opportunity to make those grafts better and to make recipient outcomes better. So my example is that I use NRP for the most part at my center. We're 100% NRP. Our patient and graft survival in over 100 cases is 98%. We have had one patient and graft loss, one-year patient and graft loss. And our median age has gone up and up and up. So our current median age in the calendar year 2024 of donors is above 60 years old. So it is very hard to argue to me that these grafts are so extended criteria or so marginal that they can't be used in other patients. And this is becoming an issue with this to me is the biggest ethical challenge with saying, okay, there are some grafts that are so marginal they can only be used in cancer patients. Honestly, I haven't found those. Those grafts that are extended criteria can be used in patients who have decompensated cirrhosis for other reasons. And so I think you still have the competition issue in that there are many patients that will benefit from deceased donor grafts. But one thing that I think is really interesting is this concept. So are there grafts that are uniquely suited for patients who have advanced cancer? This is a study that I actually just found as I was trying to figure out, like, are there grafts that we could use for patients with cancer? And basically, it's an exploratory study that's going to assess the utility of using donor organs from individuals who have either a current or past history of cancer. So there are many times where I turn down a donor offer because I'm worried about the risk of donor-derived cancer recurrence in my patients. But if I were to have a patient who has a high-risk cancer at baseline, and I think they would benefit from liver transplantation, there may be a sweet spot where there are donors that have a risk of cancer transmission to recipients, where that risk is actually lower or equivalent to the risk of the recurrence of cancer. And you could make the argument here that this is a specific population of donors that is uniquely suited to your advanced cancer patients. Now, let's talk about living donation for a moment. So living donation, I would argue, is a completely different calculus. And the different calculus is that instead of thinking about this as one recipient, one liver transplant recipient in a pool of a bunch of patients who all need a liver graft, this is about what does a living donor liver transplant offer in as compared to the other options for this individual patient, because the living donor graft is targeted to the individual patient. So what I think about when I conceptualize the ethics of living donation is more of a transplant oncology model. Patient-centered, what is the benefit of all the different options? Willingness to transplant threshold. Is there acceptable risk to utilize a living donor graft in this particular situation based on on three things: transplant center risk threshold, potential recipient outcome as compared to other options. And then the third thing is donors' understanding of the risk of to both them as well as of the outcome of the recipient. And then obviously that goes into donor autonomy. And so when I think about the question of living donation for extended criteria cancer, the question is living donor an option for my patient with advanced cancer? If the risk is acceptable and the donor is appropriately informed, then that's somebody we should consider living donor liver transplant for. Now, the reason that this is that I can say this very simply, but it doesn't really reflect a lot of practice in the US, is because there is still living donation is still overseen the same way as deceased donation. I think that's very problematic in terms of our metrics, right? We should be thinking about living donation differently than we think about deceased donation, because living donor grafts are not a public resource that is a scarce resource that we have competition among multiple patients for. So this is where we think about intrahepatic cholangiocarcinoma versus liver resection, where we have we want to say what is the best alternative approach to the management of intrahepatic cholangiocarcinoma versus liver resection. And what you can see is that in this study, again, there are many, and I'm sure that you all can quote data better than me. Median overall survival is actually pretty similar between liver transplantation and liver resection, but those who do well with liver transplantation have a higher rate of 5-year overall survival. And so compared to liver resection in patients who could have one or the other, there do seem to be survival benefits for liver transplantation in the right selected patients. And those benefits are better than the best alternative. And so when you think about living donation, you're thinking about alternative therapy rather than alternative patients who you can transplant. So conclusions here, I do think that liver transplantation has a role in the treatment of intrahepatic cholangiocarcinoma. We just have to think about that role in terms of deceased donation and living donation just a little bit differently. Traditional extended criteria grafts are less risky with machine perfusion, and that's less risky across the board, no matter who you transplant. And there are a lot of patients competing for those grafts. And so there may be, those grafts may not have a specific potential for extended criteria cancer. But I do think that considering this idea of donors with a history of cancer as a unique pool for our extended criteria cancer patients is a creative way to utilize grafts that would not otherwise be utilized. And then finally, as I said, living donation should be compared to other options for the individual patient. And we need to think about it differently in our ethical analysis, and ideally in the way that we the way that transplant center metrics are designed with respect to the outcomes of living donor liver transplantation. So with that, I want to say thank you, and I look forward to hearing the next talks.
Thank you so much. A beautiful and elegant talk. I love the topics, and it's just so right for the discussion. Perfectly on time. We'll hopefully continue with that way. But again, I'm start thinking in the audience. I really want people to start getting their minds going for the discussion. This is going to be definitely an interactive discussion, and I'm looking at, again, unfortunately, if I know you, you're going to get called on. So Drs. Lovasik, Sadat, Ellis, and Warner, start getting ready. Dr. Spencer, we'll move on to Dr. Spencer. So of course, this is a whole multidisciplinary effort in terms of treating our patients with cholangio, whether it's transplant, resection, adjuvant, neoadjuvant. So as Dr. Borja alluded to, lots of new therapies in terms of immunotherapy, targeted therapy. So Dr. Spencer will bring it home for us in terms of for resectable biliary cancers. Is there a role for some of these new therapies in that role, and then maybe even take it one step further in the peri-transplant setting. So Dr. Kristen Spencer, she leads the phase 1 program at NYU, one of the senior medical oncologists in New York. Dr. Spencer.
Great, thanks so much. And thank you, Dr. Maitel, and to the meeting organizers for inviting me to talk to you a little bit about whether it's time to incorporate some of our novel therapeutic approaches, specifically immunotherapy and targeted therapies for resectable biliary tract cancers. I don't have any relevant disclosures, and this is the outline that I have for you today. Basically, we're going to have just a very, very brief overview of outcomes in resectable biliary tract cancer as of 2025. I don't need to tell any of you this, but just to set the stage. And that'll be followed by a discussion of why I think moving effective therapies into an earlier setting might be better, with examples from some other tumor types we have in medical oncology. And then a review of the active available agents that we might consider using, balanced with some of the challenges to implementing this that we've had so far. So as you all know, biliary tract cancers are a rare and really heterogeneous group of malignancies. Right now, they include intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer, most recently with ampullary cancers really being sort of separated out and considered a completely distinct entity. What they all share is that while surgical resection and sometimes, as you've just heard, transplant remain the only sort of potentially curative options we have available, the risk of recurrence still remains quite high, and the 5-year overall survival is still under 30%, and that includes even for patients who've had R0 resections. Currently, the standard adjuvant therapy is capecitabine, and that was based on the BILCAP trial, and that really only gave us a median recurrence-free survival of just about 2 years. And as of right now, there are no widely accepted neoadjuvant or perioperative systemic therapy regimens that we've established to date. Biliary tract cancers have historically lagged behind other gastrointestinal cancers in many ways, particularly in perioperative treatment advances. And that's not because we don't need to do that, as I've just shown you. It's because of a lot of challenges we've had, those of us that have tried to do these trials, in trial design, the rarity of the disease, and as I mentioned, the patient heterogeneity. We do now recognize that micrometastatic disease is likely present at the time of diagnosis in most patients, and that's what's causing our frequent relapse. We also have come to recognize that biliary tract cancers are really primed to respond to some of our novel therapies. They have a rich molecular landscape, so we know about IDH1, HER2, BRAF mutations, among others, as well as FGFR2 fusions that were alluded to, and MSI high deficient mismatch repair, or TMB high disease. And from an immunogenicity standpoint, there are some rare but meaningful subtypes that really lend themselves to response to checkpoint inhibition or just a little bit of a nudge with immunotherapy based on their predisposing factors. So examples of that would be MSI high disease and many of our viral-associated biliary tract cancers. Immunotherapy and targeted therapy have really shown some tremendous success in the advanced setting. And so I think this is really an emerging opportunity that we have now to move these therapies earlier in the treatment course to improve outcomes. And by that, I mean addressing recurrence biologically, not just surgically. And there is rationale for using promising agents earlier for many reasons. The tumors are more homogeneous and in earlier stage of development and in the resectable setting. And that makes it really much easier for therapies to attack antigens present on a majority of tumor cells, as opposed to antigens that are present later stages of disease, maybe on a few subclones of tumor cells. Resistance also has not developed, typically speaking, although there is primary resistance. Much of the resistance that we see both to targeted and immune therapies is the result of things like genetic and epigenetic changes and activation of alternate pathways, specifically signaling pathways. As I mentioned, fewer subclones have developed with a selective advantage that makes treatment easier. Tumors are also more sensitive earlier in the stage of disease, and by that I mean particularly with signaling pathways, our targeted therapies. We know that when more cells are actively proliferating, they're more metabolically active, and we know signaling pathways are more actively engaged in those cells. We also have an intact tumor microenvironment. So as tumors grow and progress, we have increased blood vessels, immune and stromal cells that often make it really harder for our therapies to penetrate. And then there's, of course, often interactions between the agent and the immune system that are easier to manipulate in earlier stages. And practically speaking, earlier on, we have fitter patients. They have fewer treatment-related toxicities, so theoretically, they're better able to tolerate novel therapies, including multi-agent therapies. We have more combination therapy options that might make sense in patients that have fewer prior therapy exposures, and particularly many of these combination strategies that might synergize better in this setting. And specifically for neoadjuvant containing approaches, we have the ability to potentially downstage borderline or unresectable disease. There's obviously the attraction of early treatment of metastatic disease, and you can always make the argument of assessing biologic response or pace of disease. And by that, I really mean identifying non-responders who might avoid a morbid surgery. And there are many examples of this being done successfully in other cancers. So the HER2 gene encodes for the growth factor receptor HER2. That gene, when it's amplified, leads to protein overexpression in about a quarter of advanced breast cancers. And historically, this was associated with an increased risk of disease recurrence and a worse prognosis. And that was until trastuzumab came along, which is a recombinant monoclonal antibody directed against HER2. And it was first investigated as monotherapy in refractory patients in the 1990s, as we often do in medical oncology. I know Dr. Maitel often complains to us about our way of doing this, but it did ultimately get moved into the first-line setting. And you can see that in combination with chemotherapy, this same agent moved into the first-line setting, improved outcomes, including an almost doubling of overall survival. And we've seen that in GI cancers as well. So as far as immunotherapy goes, the Checkmate 577 trial was one trial that investigated the use of earlier checkpoint inhibitors, specifically adjuvant nivolumab or placebo. And this was in patients with stage 2 or 3 esophageal or GE junction cancer who had undergone first neoadjuvant chemo-RT and then surgical resection and had residual pathologic disease. And the primary endpoint of this trial was disease-free survival. And we can see here that adjuvant nivolumab improved disease-free survival from 11 to 22 months, and ultimately overall survival from 35 to 52 months. So really impressive changes here. It used to be true that we had very few tools in our toolkits as medical oncologists treating advanced biliary tract cancers, but this is a table that's summarizing the FDA approvals we've had for both targeted and immunotherapies to date in the last several years. And you can see what's really sort of a theme about all of them, perhaps except with the exception of ivosidenib in the settings of IDH1 mutations, is that we have really high response rates and they don't take that long to achieve. So these are really primed to be used in the neoadjuvant setting. Additionally, we've really seen relatively manageable toxicities of low grade. They're easy to sort of use in combination without overlapping toxicities. So these, as I said, are primed to move earlier, though to date, none of them have been studied robustly in the perioperative setting. So if everything's so great over here on the med-onc side, why are we not using these drugs everywhere? And I think that's because there are a number of unique challenges specifically to biliary tract cancers, or at least seen more frequently with biliary tract cancers. So access to tissue and time to receive results from next-gen sequencing have, I think, been the biggest limitations to our use of targeted therapies in earlier spaces so far. And in terms of immunotherapy, we've really had a lack of biomarkers that we know consistently are predictive of efficacy. And that's really done the same thing for us in terms of immunotherapy-based approaches. There are also many folks that still cite the risk of progression and surgical delays that are theoretically there. And I hear that due to toxicity profiles. And there's always the sort of old adage that we might potentially render resectable patients unresectable. And there's been to date, as I mentioned, a lack of randomized controlled trials, and it's really in this low incidence, histologically heterogeneous group of patients, and ultimately limited regulatory precedent to think innovatively to overcome these challenges. And I really like this quote from Toni Morrison, who says, "If there's a book that you want to read, but it hasn't been written yet, then you must write it." And I don't have a ton of time to look at all these challenges, but just quickly looking at two of them. It is true that in 2025, we still have diagnostic challenges in biliary tract cancers that are not seen as frequently in other tumor types. And cholangioscopy-guided forceps biopsy, I think, is one way to really try and work at overcoming these. They can offer more adequate tissue diagnosis through acquisition than brushings alone. Unfortunately, we've really seen limited uptake in many endoscopy centers even still. I've included that publication that's from 2023 that's showing out in the community, we're not using this as frequently. However, I'd also like to argue that if we were to take an adjuvant approach in these cancers, perhaps this is more feasible as we have more tissue. Also, ctDNA has really already been shown to have similar capture rates for many of our actionable alterations as tissue genotyping in biliary tract cancers, and I've cited many of these studies for you here. And I actually took a look at a number of studies that were using sort of a well-implemented ctDNA-based correlative strategy, not specifically in biliary tract cancer, but many of the studies that have led to FDA approvals in things like lung and GYN cancers. And all of them cited a turnaround time for most labs of 7 to 10 days. And so I think ctDNA offers really the opportunity for rapid, accurate, and non-invasive diagnostics to identify patients. We have also seen a risk of progression suggested in the past, and that's predominantly been done in retrospective reviews, often from the transplant literature, and I would argue not in the setting of modern therapy. So we're all familiar by now with Dr. Meitel's NeoGAP study in surgically high-risk ICC, where patients receive neoadjuvant gemcitabiraxane. And what we know from that trial is that all 30 patients completed pre-op treatment. About 3/4 or 22 were able to undergo successful surgical resection. And I'd argue that really a minority, only 5 or just under 17%, had progression of disease prior to going to the OR. So that led us to an overall response rate of 23%, and importantly, a disease control rate of 90%. And again, this was in our surgically high-risk patients. So I really imagine that studies incorporating IO and targeted treatments, including our patients of average risk, could do even better. So I'm probably at or over time, but in conclusion, I think there is a really sound rationale for incorporating targeted and immunotherapy-based approaches in earlier stages in biliary tract cancers. And we've seen prior examples of better efficacy of this approach in other cancers. However, we're nowhere near a home run in any setting in biliary tract cancers, but I do believe that the promising targeted and immunotherapy agents that I showed you in the advanced setting, coupled with the patient and tumor being better candidates in early stages, make this the optimal approach. So is it time? Yes, but I will say that with the caveats that we should also prioritize universal tissue profiling at diagnosis. We'll need the help of our hepatology and GI colleagues for this. We should include liquid biopsy where tissue is limited. We should work to identify biomarkers that will identify patients most likely to derive benefit, and we're going to need to collaborate across disciplines to design smarter trials, and I think to really push our regulatory authorities to be more accepting of innovative trial designs that are going to get us there. I think that was all I had. Yep.
Wonderful talk, Dr. Spencer. Thank you again for laying the foundation so beautifully. Again, I've had the discussion all planned out. I don't think I've ever seen 3 speakers in a row perfectly on time. I'm at single, no pressure at all. Next speaker, we're going to change gears a little bit. We're going to move to HCC. We're very lucky to have Ahmed Singhal here, who is based, you can see on all his UT Southwestern titles, but more importantly, just a world thought leader in the HCC space and in terms of how to really incorporate the regimens that we have in the metastatic disease space to the adjuvant, neoadjuvant setting. So I'll turn it over to Dr. Singhal, talking about lessons learned from I Am Brave 50 and what are the next steps for HCC.
Yeah, thanks, Shishir. I think more than sort of a little bit of angst about being a thought leader, now I have angst about the time. So I'm going to try to get this 15 minutes. So let me see if we can make 4 or 4. Here you can see my disclosures. So I decided to frame this as a case just when we're thinking about this. So, Mr. Smith, 64-year-old male, hep C cirrhosis, post-SVR, compensated. You can see the labs there and is found to have a lesion on ultrasound, undergoes an MRI, and is found to have a 5.2 centimeter HCC, no metastatic spread. And so, I think this is a typical case where one walks in. We're fortunate to find this patient at an early stage. We know that there's curative therapies available: surgical resection, local ablation, liver transplantation. And so, this is really a case, as I think everyone here knows, that surgical resection is an excellent therapy. We know that surgical resection can provide prolonged survival in well-selected patients, particularly those patients with Child-Pugh cirrhosis and no portal hypertension. And we've seen an expansion of who is surgically resectable. As we've had increasing use of minimally invasive techniques, including robotic techniques, I think more and more centers feel comfortable pushing this envelope of where do they draw the line for portal hypertension. And so it's nice because, in many centers, we've seen more patients now going towards surgical resection, particularly those that can be done in a minor fashion in a non-invasive manner. So, with this in mind, we take a look at this patient. This patient is Child-Pugh A, does not have significant portal hypertension with a platelet count well over 100,000, unifocal lesion, and so is discussed in the multidisciplinary tumor board and is recommended to undergo robotic resection. Now, good news is the patient underwent a curative therapy. And the unfortunate news is on pathology, we see a couple different features which would make this patient at high risk for recurrence. We see poor differentiation, we see microvascular invasion, and this patient already started with a larger lesion over 5 centimeters. And so this patient has a couple different features which makes this patient at higher risk of recurrence. And even though resection is curative, and I think, is and should be a therapy that is pushed when possible, I think it's important, as many of you know, that it is limited by a high risk of recurrence. We know that actually the recurrence rates can approach 50% within 2 years and 60 to 70% within 5 years. So a majority of patients do recur after surgical resection, many of them intrahepatically. And so, we do have effective therapies even after recurrence, including salvage liver transplant. And we know that some of this recurrence is early, related to dissemination of the primary tumor, and some of this is late, the majority of those being de novo. Now, I show you this figure that actually comes from an analysis looking at the benefits of antiviral therapy, which shows that the benefit of different therapies may impact early recurrence versus late recurrence in a different manner. Antiviral therapy, reducing the risk of de novo tumors, whereas effective adjuvant or neoadjuvant therapy would presumably have a higher benefit for early recurrence compared to late recurrence. But I think that when we think of this, it's different than other cancers because of this continued high risk of de novo tumors over time. So now getting closer to this discussion of adjuvant therapy, I think everyone here is aware that we started with the STORM trial previously, comparing placebo versus sorafenib in an adjuvant manner. And as many of you know, sorafenib failed to improve recurrence-free survival compared to placebo. Now, like many discussions, the discussions of where systemic therapy should fit in was completely rethought once we started after the introduction of immune checkpoint inhibitors. Among them, we have the introduction of atezolizumab plus bevacizumab, proven to be beneficial in the IMbrave 150 trial. So this is in the systemic therapy advanced stage or unresectable setting. In the IMbrave 150 trial, atezo-bev was compared to sorafenib and was shown to be significantly better than sorafenib by its primary endpoint of overall survival, co-primary of progression-free survival, as well as significantly higher objective responses, 30% responses with atezo-bev compared to about 11% with sorafenib. And you see those responses, as with many immune checkpoint inhibitors, being durable in nature. And so the IMbrave 050 was looking at how well this regimen worked in the adjuvant setting. And so what you can see here is that these are patients who had a confirmed diagnosis of HCC, Child-Pugh A. They were at high risk of recurrence after either surgical resection or local ablation. And you can see the high-risk criteria defined in the lower left corner. This could either be large tumor size, multiplicity, or poor clinical pathologic features, microvascular invasion, minor macrovascular invasion, including VP1, VP2, or poor tumor differentiation. And so going back to our case, we can see that our patient had a larger tumor, greater than 5 centimeters, had poor tumor differentiation, and had microvascular invasion. But it is a high-risk patient, but one that typically fits within our sort of like everyday clinical workflow. This isn't a true, very high-risk, crazy surgical resection. These patients in IMbrave 050 were randomized to receive atezolizumab plus bevacizumab at their traditional doses given for 12 months, i.e. 17 cycles, and this was compared to active surveillance, about 334 patients in both arms, with the primary endpoint of recurrence-free survival. Notably, patients at the time of recurrence were allowed to cross over, and so that was notable for survival outcomes. When we take a look at the IMbrave 050 patient characteristics, you can see not unexpectedly, a majority of the patients were Asian in nature, so over 70% coming from Asia. You do see that in parallel, about 2/3 of the patients had hepatitis B, about 10% had hepatitis C, although over 10% of the patients had non-viral etiologies. The majority of patients did have had BCLC stage A disease. So when we take a look at this, the trial did allow multifocal tumors. It did allow VP1, VP2, but you can see that the majority of tumors were unifocal. 90% were unifocal. The majority were larger lesions over 5 centimeters, microvascular invasion being present in 60%. Less than 10% had VP1, VP2, and only about 40% were beyond up to 7. So once again, I would argue that from a surgical resection patient characteristics, this parallels many of the patients that undergo surgical resection in the Western world. Now, the interesting thing about this trial, the first interim analysis suggested a recurrence-free survival benefit. You can see here, the first interim analysis at 12 months showed a recurrence-free survival estimate of 78% versus 65%, the hazard ratio being 0.72, and this was statistically significant with an upper bound of 0.93 and a p-value of 0.01. Now, although all of these things looked promising, it is notable that the curves separated and then converged over time. In parallel, we did not see a survival benefit, even a signal for such at the first interim analysis. As we started to follow this trial out longer, that benefit for recurrence-free survival faded and was no longer observed with continued follow-up, as the median follow-up then was extended to 35 months during the second analysis. You can see here median recurrence-free survival of 33 months versus 36 months, and this difference not being statistically significant. Further, the results for recurrence-free survival were consistent across all examined subgroups, although there was a signal for some benefit amongst high-risk groups, right? When you take a look at patients who had multifocal disease, you get a hazard ratio of 0.75, poor tumor differentiation, hazard ratio of 0.83, and beyond up to 7, a hazard ratio of 0.84. Now, these subgroup analyses are not definitive. They're not statistically significant, but they do suggest that maybe some of the issue here is patient selection in terms of truly having a sufficiently high-risk group in whom adjuvant therapy may be beneficial. When you take a look at this, here you can see the KM curves for within up to 7 versus beyond up to 7. And so once again, when you're within up to 7, those curves are nearly overlapping with no benefit at all for adjuvant therapy. Conversely, those patients who are beyond up to 7, so the sum of the tumor size plus number exceeding 7, you can see that there is at least a signal potentially for adjuvant therapy maybe being beneficial. So once again, not definitive, but maybe if we're looking for how we can rescue future trials, maybe better patient selection may be a way to go. Overall survival remained immature even at this more further follow-up. However, there was no signal for any potential benefit in overall survival. You can see there the curves highly overlapping, hazard ratio, if anything, above 1. And this is important when we think through any potential benefit of adjuvant therapy, because this is not a therapy that comes without potential adverse events. And when you're talking about these adverse events in somebody who has unresectable HCC, particularly if you're thinking about this in the advanced stage setting, I think our weight for these treatment-related AEs is different than when one is considering this in a patient that is simply for prevention of recurrence. And so here you can see grade 3-4 treatment-related AEs observed in 36% of patients. And so I think we really need to think through, as we're thinking about adjuvant, maybe neoadjuvant, as I'll reference in the last 3 minutes, I think we really need to think about the AEs in parallel. Now, it's notable that we have negative data from IMbrave050, and I think that at the end of the day, IMbrave050 is a negative trial. We have several other trials that are awaiting data to be reported. We see single agent checkpoint inhibitors, and we do see EMERALD-2, which is looking at durvalumab plus minus bevacizumab. Looking at this, I personally have a hard time seeing any of these report out as positive after seeing IMbrave050 being negative. I don't want to say that definitively because there are small nuances that are different between each of these trials, including how high-risk populations were defined. Obviously, the agents are different. There may be different lengths of therapy. All of these things may make a difference, and we can talk about this during the discussion period of how much each of these factors may make a difference. If anything, I think the first one is the most interesting when one is thinking about an adjuvant therapy trial in terms of how do you define high risk where adjuvant therapy may be beneficial and it's not too high risk where like that horse is out of the barn. The other thing that I think is worth as a lesson from here is that we can't celebrate trials too early. When you took a look at this curve was non-proportional. As I mentioned, it separated and then it came back together over time. One of the things that we assume when we look at KM curves and you look at those hazard ratios and you look at those p-values is the proportionality of those curves over time. Now, this is always written in the methods, and it's always one of the assumptions that goes into the analysis, although it's often one that we don't talk about very much. But as we look at immune checkpoint inhibitors, it is something that I think we need to become more cognizant of in terms of, are the curves proportional? Do you expect increasing separation over time, like you saw in Himalaya, like you saw in the Checkmate trial? Or are you going to see decreasing benefits over time, like we saw in IMbrave050? And so I think assessments for proportional hazards and thinking through alternate analysis methodology is something that is also worth considering when looking at these trials. The final couple slides I have is saying that, much like you heard from Dr. Spencer in terms of earlier treatment may be better for multiple reasons. I won't repeat the rationale, but I think that there are multiple reasons why neoadjuvant therapy may be more beneficial than adjuvant therapy, including the greater availability of neoantigens for the immune checkpoint inhibitors to act and be primed by. We saw this in melanoma, where there was a very elegant trial that was published in the New England Journal just this past year, where we saw a significant benefit of the use of neoadjuvant therapy compared to adjuvant therapy, really underscoring the importance and the promise of neoadjuvant therapy. And there have been early data in HCC showing high objective responses, major pathologic responses in a large proportion of patients, including patients with resectable disease and patients even with borderline resectable disease. I think we do need to see larger trials. We need to see if this translates into benefits with recurrence-free survival. But I think the early data are promising, at least in terms of how neoadjuvant therapy may be beneficial. And finally, before my sort of summary slide, I'm going to say that all of these discussions should be made in a multidisciplinary manner. It's important to have discussions with hepatology, medical oncology, IR, surgery, et cetera, in terms of really thinking through how we should treat these patients. In summary, surgical resection provides excellent survival, but limited by high risk of recurrence. Adjuvant therapy with atezo-bev failed to improve recurrence-free survival, relative consistency of results across multiple subgroups. Lessons learned, important to consider non-proportional hazards when interpreting future trials, as well as thinking through patient selection for adjuvant trials. I would argue, I think there's much more interest now in neoadjuvant therapy as the future approach. As I talked about, even for adjuvant therapy, we need to think through patient selection. It will also be something that we need to think through for neoadjuvant therapy. And then, as I briefly mentioned, we need to really weigh potential benefits versus adverse events, including the risk of progression, potentially falling off, resectability, like brought up by Dr. Spencer. And my final point, decisions regarding neoadjuvant therapy should be made in a multidisciplinary format. Thank you.
Excellent. 4 for 4, just brilliant talks and perfectly on time. I've never seen 4 talks go perfectly on time. To the audience, just so you know, I know Dr. Single you may all think he's a medical oncologist because he knows the oncology data cold. He's a hepatologist, hence my comment, world thought leader. He knows the data cold in HCC. So we'll start the discussion. Again, we have such great data here ripe for discussion. We'll start at first in biliary tract cancers, and Amit, please chime in on anything and all the above. First question, really to Dr. Wall and also to the audience, please, again, just raise your hands and I'll try to get everyone involved. Dr. Wall, you mentioned a little bit about the ethics in terms of going toward transplant for ICC, using the results in HCC transplant as the benchmark to really say, is this a reasonable therapy? So my question to you is that the right baseline or foundation to use? Is it really fair to compare it to HCC, or should we be using the outcomes with systemic therapy, resection, liver-directed therapy? Because if you look at systemic therapy, we have a 15, 25% 5-year survival. If you look at all-comers resection, it's about a 35% 5-year survival. And with liver-directed therapy, again, in well-selected patients, it's maybe about a 30% 5-year survival with a median of about 30 months. So again, knowing albeit that patients for transplant are well selected, so those numbers may not be apples and oranges, like apples to apples comparison. But what is truly the best foundation to use in order to really grow this concept of transplant for intrahepatic cholangio?
Yeah, so I think it comes back to what your comparison is in general, right? And so with HCC, the comparison was to other patients who have indications for liver transplantation. And so what is an acceptable overall 5-year overall survival versus anyone who can get a liver transplant, because of the underlying fact that if you're going to give MELD exceptions, then you are making those individuals competitive for a graft that other patients will benefit from. And so the ethical analysis about it's not just about urgency. It's also about equity in terms of outcomes. Are there going to be equal survival? Or I guess maybe thinking about it more in terms of what is the best utilization of this graft? Meaning, who is the sickest person who will benefit from it, but who will benefit for the longest amount of time from this graft? And so that's where we get into problems when we think about what do we compare our transplant outcomes to? In living donor, I completely agree with you. I think that it needs to be that with living donor liver transplantation, the comparison needs to be what are the other therapies that are available to the patient, and what are the predicted outcomes for those? Because in the case of living donor liver transplantation, this is not a graft that you're not going to have a living donor who's just going to give to anybody, right? In this case, this is a graft that's directed to an individual. And so you can make the argument that you're not taking a limited resource out of a pool that would benefit other patients. You are utilizing a therapy that is specific to that individual.
Yeah. Dr. Borja, as machine perfusion gets more and more available, and as we get more competitors in the market and the prices come down, and we kind of start chipping away at the limitation of the donor pool and using extended criteria donors, do you think that this target, this baseline foundation that Dr. Wall speaks of, do you think that's a moving target as we expand the donor pool with machine perfusion?
Yeah, I think that we should, as the transplant surgeon community, we should try to increase both. I agree with that. With machine perfusion, we're definitely increasing the number of grafts that are available for most patients. However, I also see an increase in the need of liver transplantation. We may be seeing a decrease in the incidence, for example, hepatitis C, hepatitis B, but we're seeing an impressive increase for NASH, acute alcoholic hepatitis, now transplant oncology. So I don't think that pushing just to do living donors or just to do machine perfusion is gonna be enough. I think that as a transplant community, we should try to improve both. I personally think that a good transplant center should focus on improving both programs.
Yeah. Okay. So now let's say we have a patient who's ready for transplant or ready for resection. Let's spend a little bit of time talking about pre-resection, or more importantly, pre-transplant therapy. So we have options of liver-directed therapy, Y90, even hepatic arterial infusion pump in terms of controlling the liver while we're on that waiting period. We have immunotherapy and we have targeted therapy. So Dr. Spencer, you alluded to this a little bit. Right now, there's no standardized pre-transplant therapy paradigm for intrahepatic cholangio. Some centers use one thing, some centers use certain months. The months vary, the durations vary, the drugs vary. Talk to us a little bit about incorporating targeted. Like, we don't have targeted therapy in the first line for metastatic. Is it too much to start? Let's say we have a patient with an FGFR2 fusion who is a candidate for transplant, no extrahepatic disease, unresectable. Is it too much to say we're going to bring in futibatinib in the first line, given the response rates of 40-50%, or do we need to stick with chemo? Where does immunotherapy fall? Talk us through that a little bit.
Yeah, I think it's a tough question, I think, to answer without really getting better at using our sequencing platforms and our sequencing technology that is just a little bit more that can, get us information faster. I think that's our biggest challenge at this point in time. That doesn't mean that we can't, for instance, get a diagnosis with the partnership of our, endoscopists or GI or hepatology, get that tissue or even that ctDNA sent off earlier and do better. I think that's where we need to work first. And we can certainly get a diagnosis and start our regimens and incorporate targeted and even immunotherapy in at that point, once we have that information. But I think the problem that we really run into is, as you know very well, we've let sort of perfect be the enemy of good when we're designing these trials. And I think, nobody wants to let folks get a cycle of anything and then add on the targeted or switch to the targeted, as if one cycle is going to like suddenly make such a difference and cloud the response forevermore. I mean, obviously we know that, GemCis, if you're looking at patients that were, say converting to resectable, we know GemCis Durva is not a slam dunk for everybody. So, what's the problem with designing these trials a little bit more pragmatically? I think that's the biggest challenge. So, I mean, to answer your question simply, yes, I think we should, we can and we should. It's just going to take a little bit of a culture shift in how we think about patients and how we collaborate.
Yeah. So as maybe for both to Dr. Borja and Dr. Wall, and we'll ask Dr. Levasik his opinion from his experience at WashU, in terms of immunotherapy, again, targeted therapy is something we're working on. We're working on a trial right now, a multi-institutional trial to use targeted therapy in the pre-neoadjuvant resectable setting, not for transplant. But for immunotherapy, how do you guys feel about that? I know there's some now more and more literature coming out, which is, again, limited number of patients, but using immunotherapy in the pre-transplant setting. And then also, please talk to us a little bit about how do you time the immunotherapy in the living donor, which is fine. You have a scheduled operation. You can time it based on a living donor. But what about in the deceased donor situation? How do you time the immunotherapy in terms of trying to get off it prior to transplant? And what are your thoughts about that? Let's start, Dr. Borja. Why don't we start with you, and then we'll go to Dr. Wall.
I think that we started extremely conservative, following a little bit with HCC because of the reports that there were with patients that develop immediately after transplant, very aggressive forms of rejection and needed to be retransplanted or die. So we were very conservative, and very slowly, at least here in our institution, we have decreased to 3 months. I think that if you are planning to, we have not done it here, but if you are planning to do immunotherapy in addition to cisplatin for these two more, I think that you should keep the patient for those 3 months that you're waiting for the immunotherapy to wear off with gemcitabine and cisplatin. And if you have a living donor, you can make it the timing very perfect, like you would normally do for your resections. If for any given reason your pool of living donors is not available, you just keep these patients on a systemic therapy with gemcitabine cisplatin, like they did in Houston Methodist. That's what they did. They were not able to predict, so they will give gemcitabine cisplatin. So I think that to answer your question, I think that if you are using immunotherapy for this particular cancer, I would stop 3 months before the transplant and then continue the patient with the gemcitabine cisplatin to avoid progression of the disease.
Mhm. And given the wait time, if you gave 3 months, you'd safely have that 3-month washout period with a deceased donor situation as well, where you can't necessarily predict the exact timing, correct?
Correct.
Yeah, okay. Dr. Wall, your thoughts in terms of any experience with using immunotherapy pre-transplant for this
Well,
population?
what I would say is that one, that also speaks to the specific benefits of living donors. So it's not just about, I think that one of the reasons that the outcomes with living donors in the US are better than the outcomes with deceased donors is because of the fact that that you can time the living donor. So you have, you can do an oncologically favorable transplant in terms of timing all of the other therapies around it. Thinking when I think about who I'm gonna list in terms of deceased donor transplants and how I'm gonna deal with in particular open offers, what I would say is that there's probably an opportunity for transplant centers to have some sort of game plan with these are the number of patients that we can safely treat and consider for liver transplantation. And when you activate them onto the list, having those as your targeted open offer patients, it's still, I mean, you can't guarantee timing of a liver graft, but you can. And there are many centers that do this anyway, even without like oncology patients. It's just that, we have a handful of patients that are good candidates for an open offer. And if you're going to think about transplant oncology, you should really think about the open offer timing, target this patient when you activate them. They're the go-to for the open offer.
Yeah. So in terms of like liver-directed therapy, so while you're waiting, right, obviously these patients have no extrahepatic disease, no lymph node disease, it's the liver only. What are your thoughts, both of you, and again, we'll ask Dr. Levassa to comment on this as well, in terms of liver-directed therapy to control the liver disease while we're waiting, right? So Dr. Borja alluded to biologic selection versus these absolute numbers we put, right? 2 centimeters, 3 centimeters, we'll get to that in a second. But what are your thoughts of Y90 or hepatic arterial infusion pump as a liver-directed therapy, control the liver as a bridge to transplant during that 3 to 6 month wait period before we transplant, barring any technical issues with the pump, of course. Dr. Wall, what's that?
So I don't have a ton of experience with this, but I would like to hear, I know from others' experience, especially with the hepatic artery infusion pump, that you can burn bridges with that. So it can make the subsequent transplant harder. And in particular, doing a living donor, if you kind of burn the artery and you have to do a conduit or you have to do some sort of creative, like splenic artery or something like that, I think that can be problematic in your planning for what your next step is going to be. Again, I don't have experience with using the pump, but that is my concern specifically, is that you do burn bridges in terms of making the transplant technically more challenging, and particularly making the artery less ideal for a living donor.
Yeah. I think usually a transplant after a pump, you're gonna basically be doing an arterial conduit and a route to the bile duct. I think Dr. Borja has done I think 1 or 2 here, but let me ask Dr. Levassa. I know he's finishing his fellowship at WashU, but did have the privilege of training with Dr. Doyle, who I think has probably one of the biggest experiences of transplant after pump. You want to comment a little bit on your experience at WashU?
Yeah, so first, from the immunotherapy side, just wanted to weigh in. We, very similar to Dr. Borja, we have an 8-week washout period before we'll have any immunotherapy, and we typically just hold them on, we'll put them on a hold on our waiting list so that people aren't getting unactivated and we're turning down offers. From a liver-directed therapy, we do use primarily Y90, not necessarily TACE as much. But we will use Y90 as a bridge to transplant for those people who are on the pathway. We use primarily GemCis. We do have a few of the people who are on clinical trials for immunotherapy. They are also candidates for liver-directed therapy at the same time. And then from a pump standpoint, we've actually had, Dr. Doyle published this, I think 2 years ago in Annals of Surgical Oncology. We've actually been able to use primarily off the common hepatic artery without having to do a conduit. So in my fellowship, I've done 3 transplants after HEIP, and we've been able to go directly off the common for each of them with good results. So I think we have not had the similar problematic experience from an arterial standpoint, but that may just be the patients that we've received.
Excellent. No, excellent. I think lots of opportunity as we move forward in this field in terms of incorporating the multidisciplinary approach to optimize the outcomes, not only for transplant, but for resection. Let's shift gears a little bit toward indication. So Dr. Borja, you were kind of going through the whole thing about the initial experience with intrahepatic cholangiocarcinoma was almost by chance, right? They basically thought they were setting for HCC. They found 29 patients with ICC, and this is where this 2-3 centimeter thing came in. But then again, you very elegantly alluded to it's the biology of the cancer, not necessarily the size. So maybe speak to us a little bit. And then when you look at the Houston Methodist experience, they're doing definitely way bigger than 2 centimeters, multifocal. Again, it's 3 to 6 months of chemo. So trying to biologically select, and they're reporting a 50% 5-year survival. So tell us, how is the field going to change? How are we going to get the UNOs to change the exception points? Because right now, a solitary less than 3 centimeter intrahepatic cholangio, it's a hard one to come by, and unless it's instantly found in someone with cirrhosis. And then Amit, I'd love your thoughts on this. And again, extrapolating from the HCC side of things, in terms of how Milan came about and how we've kind of extended Milan criteria in different ways after we hear from Dr. Borja.
I think that from all the tumors that we're starting to do in transplant oncology, intrahepatic cholangiocarcinoma is going to be the slowest. Actually, I think that it's going to be slower than colorectal metastases and HCC and neuroendocrine tumors. I think that cholangiocarcinoma is a little bit trickier because it's the same size doesn't mean, like you were saying, the same biology, right? We need to see where the tumor is arising, analyze a little bit the risk factors. We know that there's every once in a while patients that respond very well to chemotherapy. So I think that we need to learn a little bit better how to identify these patients. I think that like neoadjuvant therapy in other hepatopancrearobiliary malignancies, we need to use it properly to select patients. We know how to do the operation. I don't think that the operation has changed the past 15, 20 years. I think that truly what has changed in transplant oncology is the rise of multidisciplinary teams, the communication between surgical oncologists, medical oncologists, hepatologists, and have a little better selection of the patients, and also better therapies, right? The transplant, really, the technique has really not changed the past 15, 20 years, but what has changed is all these new medications that we have been listening to today. So I don't think that transplant oncology is getting better because the technique is getting better. I think that transplant oncology is getting better because we have other forms to bridge the patient, like you were alluding, like the hepatic artery infusion pump, like Y90, like immunotherapy. And that's the reason why patients that had very poor prognosis in the 90s now can be done.
Yeah.
Yeah, Shisha, to your question, I think the parallels with what we've seen in HCC and what we're seeing in cholangio are sort of right on, right? I mean, like you think about HCC, we had a moratorium on transplant for HCC, then we rescued HCC transplants with the Milan criteria. Then we're like, Milan criteria is too restrictive, we expanded it. Then we're like, oh, it's not even tumor size and number, it's a biology game. And now downstaging is the standard, right? I mean, like we have UNOS downstaging criteria. Many centers are, if you're beyond UNOS downstaging, including VP1, VP2, you have an incredible response. We're like, okay, we'll do you by living donor, et cetera. I think cholangio is going to do that exact same thing. We're like, cholangio, you can't transplant intrahepatic. Then we're like, very early stage, you can. That's our Milan. Then very early stage, we're like, it's too restrictive. I mean, we're playing the same game, and hopefully we're not so slow, right? Hopefully it's not 20 years of the same thing. I mean, I actually will respectfully disagree with I think it's going to be much faster. I mean, like, honestly, like, I gave a talk 2 years ago. I remember this. I gave it at sort of one of the surgical society meetings and got blasted because I gave the traditional, very early stage, sort of conversation. And rightfully so. I mean, I was sort of like a conservative thinker then. And I gave like a very similar talk this year in Korea. And I was like, I mean, I don't know if I was like on cutting edge, but I was like much more than I was 2 years ago. And I was like, okay, fine. Like, it's not a tumor number and size thing. It's all biology. And I was like, our center now, we feel comfortable with a larger ICC that gets sort of downstaged with a good response that's durable. I advocate strongly for a living donor, independent of that size up front. I mean, we're not Houston Methodist, but I mean, I think we're trying to at least be more aggressive for our patients. And I think that I will add, you talked about pump and you talked about radioembolization. We actually do a lot of SBRT, so I just want to put that out there as another sort of, therapy for downstaging,
Absolutely.
bridging, that you can also deliver high doses of radiation. But we do a lot of TARE, we do a lot of SBRT as our sort of bridging and quote unquote downsstaging therapies for intrahepatic, and we've seen some excellent responses.
Yeah, no, excellent.
Can I
Yeah, go ahead.
add one question just to the group, because I think that this is really important. Like there are some centers that have a ton of experience in different types of liver cancer, and in particular have all of the different modalities for treatment. Do you all think that this is something that should be done across the country in every center, or do you think that we should have specialized centers for the treatment of advanced cancer?
I mean,
Yeah, and Dr. Single, you want to?
yeah, I mean, I think it's hard because you want to balance having expertise, but you also want to balance having it be available for all patients. I think this like centers of excellence idea has been one that has been proposed in several surgical fields. And then, and we both practice in Texas. I mean, like, my patients complain when they have to drive an hour into Dallas. And I'm like, come on, it's not that bad, right? I mean, like, then you're like, okay, no, you have to drive across the entire state of Texas to get here. You're like, that's not gonna. So I think that like we have to balance this of having it be available. I would argue that telehealth also now offers availability to other centers. I think you need to have certain numbers. I think there's probably a minimum criteria, but I don't know if we can regionalize the care as much as we would like for having true high volume centers who do this. I'm hoping, I mean, Shishir, I think that I don't know if I thanked you for putting this together, because I think that conversations like this expand, the number of centers that go out there and make us think, on that cutting edge of saying, oh, cholangio isn't just very early stage. Maybe we should go back and discuss with our group. Maybe we should be thinking about, more aggressive TARE, SBRT, and then working together as surgical oncologists and transplant surgeons of like which one should go down the transplant route. But I mean, it's a great question. I just, I don't know if we're going to solve it by regionalization. I think we just need to do it by education and
Yeah.
and
I think you guys all are kind of alluding to my next kind of point of discussion is standardization, or how do we as a group come together? Obviously, this is a multidisciplinary effort. We need our medical oncologist, we need our IR, we need our radiation oncologists, our transplant surgeons, our surgical oncologists, everyone. So maybe Dr. Spencer, to start with, how would you propose, because there's, when we talked about doing these in select centers, you need to have medical oncologists with expertise in biliary cancers, HCC, and cholangio. How do we propose to come up with a standardized regimen? Because right now, every institution is doing their thing. So as a group, we have to come together with a protocol or a trial, or it doesn't even have to be a randomized trial. It just needs to be a registry type trial where everyone agrees to do something and we study it. Everyone gets this therapy, they get this biopsy, NGS. If NGS positive, you could imagine a multi-pronged management where if they have certain targeted therapies, and again, you spoke of, time to response, duration of response, objective response rates, right? Where ivosidenib for IDH1 may not be the greatest thing to use in these pre settings, but how would you think the medical oncologist would respond to try to standardize this? And then we'll talk to the transplant surgeons, how they would think about how would they do this?
I think the medical oncologists would be on board with this. I don't know that that's where the barrier is. I think that for some of the issues that I mentioned, or the reasons that I mentioned, the diagnostic challenges, time to sequencing, you may need to have a large group of academic centers. As much as we want to broaden access to this, that may be where it needs to start, because you need to have folks that are, aware of cholangioscopy, that are aware of sending sequencing, that are aware that earlier is better. And then I think that the key to this is sort of like what you did with your trial is really a wheel and spoke model, where we need to be working on bringing the trials to the patients. At least the standard of care stuff needs to especially be able to go out into the community. And that's how we need to get more folks involved. But I mean, that's my take on it.
Yeah, maybe to the transplants, Dr. Wall, like, do you think the transplant community is ready to come together with someone taking, because we actually had a cholangiocarcinoma foundation meeting where this was one of the priorities. And, you know, Carrie Lunsford was leading our transplant group on that discussion. And one of the priorities of research was we need to do a protocol. We need to do these registry protocols where we're actually studying this in either a multi-institutional or a single institutional, preferably multi-institutional way. Do you think the community is ready to start doing this?
So two thoughts on that. One is that the ASTS has been really thoughtful about trying to do team science. This is not cancer related, but we've put together a team science approach to normothermic regional perfusion along with machine perfusion, where what we're trying to do is develop a database that that addresses the specific questions that go along with that innovative technique. And what we're hoping is that we can use that model to create other team science approaches to innovative types of transplantation or reasons for transplantation or whatever. And so I can see this as another opportunity for the ASTS to use the team science model for registry, for you know, multi-center evaluation. I think the other thing that's really important about when I think about going down the route of considering liver transplantation and the pathway for advanced cancer is that it takes a little bit different of a mindset and an approach in terms of like how you talk to patients and counsel patients. And so I have been pushing this at my center to say, you know, usually when we see a patient with decompensated liver disease, we tell them you need a transplant, we put them on the list, we transplant them, and, you know, life continues and it's fine. And I think that when you address an intrahepatic cholangio early, for example, then you have to say, well, X has to happen and Y has to happen and Z has to happen. But we want you to identify a living donor because at the end of the day, that's going to be your pathway to the best success. But we have to get through all these steps. And transplant at the end of the day is not guaranteed. And we all as a team have to come together and be very clear about when to stop and when to pivot in the pathway to transplantation. Because if we don't do that, then we're going to be transplanting patients that shouldn't be transplanted. So I think we just have to be careful about our approach.
Oh, beautifully said, beautifully said. Let's spend a couple of minutes on HCC. I was going to talk a little bit, you had mentioned expanding the donor pool with using cancer, like donors with cancer. Obviously, there's going to be a huge selection, indolent cancers, long DFIs. I'm sure that raised a little bit of the hairs on the neck of some of our medical oncologists, or even, you know, Lily Sadat. I don't know if you have one quick comment. She's our newest faculty member joining Memorial in a couple of months. Any thoughts about donors with cancer going to another patient?
Yeah, you know, I think it's an interesting question, mostly because I think as we start to expand indications for who can be transplanted, the problem is going to be availability of organs. And so I do agree with Dr. Wall that we need to start thinking outside of the box in terms of what organs are available and kind of pushing the limits in terms of what we choose to offer in terms of marginal organs. That being said, I don't know that there's sufficient data to really kind of make a definitive statement as to the safety of doing that and kind of what the long-term implication of that will be in terms of cancer recurrence. So I think we still need to do a little bit of work in that space.
Yeah. Dr. Singhal, regarding HCC, so, you know, you showed us the adjuvant data. There's 5 other adjuvant trials. On the assumption your prediction is true and they're all negative, I think doesn't necessarily kill the perioperative thing for HCC, but really just strengthens the need to study it in the neoadjuvant space, as you mentioned, with antigen presentation and all that. So talk to us a little bit. How are we going to organize and arrange a neoadjuvant study for HCC, whether it's transplant or resection? Let's maybe focus on resection. How are we going to get the US more involved? And what is the ideal drug choice? You know, we've used immunotherapy, but now we have TIGIT, LAG-3, all of these things. How are we going to pick the right trial to do?
Yeah, I don't know if I have the answers for all of this. So if I did, I'd be probably paid pretty well as a. But yeah, so it's a great question. So I think that, you know, I think, you know, the first thing is to get folks in the room together. I think that, you know, We would need centers to agree in terms of what is the appropriate length of therapy. I would argue that's, maybe a couple cycles, 2 to 3 cycles. You'd have to, the consideration of bevacizumab is one that would also need to be discussed. I think it was easy, arguably, to do a tezo-bev post. If you're doing it pre, I think many people would want to have it held during that last cycle going into the surgery. The newer therapies, TIGIT, LAG-3, et cetera, I mean, those are being evaluated in the advanced stage setting. I don't know of any of those data coming into the neoadjuvant setting yet. As far as I've seen early data, I think most of them have been, PD-1, PD-L1. There's a Cabo, a Tezo study, Ipi-Nivo. Then there was also Libtayo as well, I think, is sort of the 3 that I know. I'm sure there's others as well. But I think that most of them have used approved agents, not these emerging ones. And I think that I would argue that we start with the proven therapies in the advanced stage setting, because we know that they can be well tolerated, that they can be efficacious. And honestly, the data for a single agent looks pretty reasonable, right? I mean, like you take a look at those, you do see responses in a sizable proportion of those patients. I think I would probably start with the proven agents. I think to your point, we do need the US to be more involved. Although when you take a look at where the predominance of surgeries happen, I think it's going to be still a majority of these coming from Asia, because of the need to enroll quickly. But I will say one other thing, and I'm just going to say this because this is my soapbox here, is that I think one other thing that I somewhat get is my pet peeve is patients who are surgically resectable, who are pushed to transplant simply because they quote unquote have cirrhosis. And at no point is that a contraindication to surgical resection. And if the US wants to get involved in, these kind of studies, I think that as a sort of group, we need to become more aggressive with our use of surgical resection.
Excellent. All right, well, listen, it's 6:32, fantastic discussion. I want to really thank again, Drs. Borja, Wall, Spencer, and Single. Fantastic talks, perfectly on time, great discussion. Thank you all to the audience for sticking around. Again, thank you to Jill, HPBA, and of course, Genentech for sponsoring it. I hope you all enjoyed it, and have a good night. Thank you all.